Okay, good afternoon, everyone. Thank you for joining this week's National Bleeding Disorder Foundation, formerly National Hemophilia Foundation, Wednesday webinar. I'm Samantha Carlson. I'm the Director of Research and a previous social worker at NVDF. This webinar is being recorded and will be available to the community and the Foundation's website at bleeding.org. We're delighted to focus this special edition of the Wednesday webinar focusing on the Research Journal Club and reviewing the research that was done by some social workers in the last couple of years about the social work role in hemophilia treatment centers. We encourage you to ask any questions that you may have today. You can ask them in the chat using the Q&A, and we will focus on answering those questions at the end of the webinar. I'll moderate the questions and make sure our presenters have enough time to address them at the end. Today, we're joined by 3 NBDF Social Work Working Group members, Kathaleen Schnur, the current chair of the Social Work Working Group at the Hemophilia Treatment Center of Western Pennsylvania, Amy Wilson, who is a previous chair of the Social Work Working Group and is a clinician at the Center for Bleeding and Clotting Disorders at Fairview at the University of Minnesota, and Diane Bartlett, current Social Work Working Group member and program manager and social worker for St. Luke's Hemophilia Treatment Center in Boise, Idaho. I will turn over the presentation to our speakers.
Thank you so much for the introduction, Samantha, and thank you to the National Bleeding Disorders Foundation for having us here today, and as well as thank you to all of the attendees tuning in. Diane, Kathaleen, and I appreciate the opportunity to share our research and spark further conversation about the social work role in the HTC and how it has evolved with all of you today. You can go to the next slide, please, Samantha. So today, this is essentially how we're going to be spending our time. We will be reviewing the Social Work Excellence Fellowship that we were awarded in 2020. As a result of that, we do have a publication published in Hemophilia in July of 2022. The title is Defining the Micro and Macro Roles of a Hemophilia Treatment Center Social Worker in the United States from an Interdisciplinary Team Perspective. So we will be discussing the views and attitudes of what the social work role is among the broader Hemophilia Treatment Center team and review knowledge gaps about our capabilities. And at the end, as Samantha said, we'll be wrapping up with a question and answer. Next slide, please. I will be starting with some of the background before handing it off to my colleagues to finish presenting. But social workers have long been a fundamental part of comprehensive care in bleeding disorders. Our discipline is listed as a core team member on the comprehensive team, along with a hematologist, nurse, physical therapist, and specialized lab. And then, of course, a whole host of other resources and support members. MASAC document 269 has a high-level overview of various roles and components to comprehensive care. So a group of us on the Social Work Working Group began talking about our role specifically at the National Bleeding Disorders Conference in Anaheim back in 2018. As we all know, patients are living longer. The health system is increasingly complicated, more and more frustrating to navigate. The mental health challenges and impacts, especially post the COVID-19 pandemic, is more widely recognized. We are on the other side of the HIV and AIDS crisis, and treatment options are evolving for our patients. Our role is shifting right along with that as psychosocial needs have changed. One thing that's always struck me since joining the hemophilia or the bleeding disorders community a decade ago is that clinicians, everyone I've worked with, just seems so highly independent. We all really rely on and trust others to be the experts. However, if we don't have a firm grasp on what our colleague does or what their skill set covers, it just asks the question, is that optimal patient care? Is there room for improvement in how we meet the psychosocial needs of our patients? From that conversation in Anaheim among social work members, a task force was created to look at this more closely, and that evolved into a research project. Next slide, please. So medical social work has been around for a very long time. It started at Mass General in 1905. Essentially, at that time, people would leave home to receive care in a hospital, and treating physicians realized they couldn't leave their personal and home life behind. Insert recruitment of social workers. Research confirms that a distinction of roles is necessary. Not only I need to confirm and have a handle on what my role is, but what is my colleague's role? So taking time to do role definition work minimizes both provider and patient confusion when it comes down to it. A study done previously by other HTC social workers indicated that social work roles in an HTC, again, defined by other HTC social workers, falls into 6 large categories. The time spent within each of these categories, it was revealed, isn't ideal based on the social worker's clinical judgment. Some of that is because we're called to do things above and beyond or seemingly simple. It's kind of on a whole continuum. As we dug further into this, we realized that other social workers in interdisciplinary teams, oncology, clinical trials, pain management, BMT, they indicate similar findings about the role. There's a lack of understanding, and that leads to an underutilization of the skill set. The social work profession incorporates training and knowledge of psychosocial risk factors for health and development, as well as expertise in behavioral health screening, assessment, and also use of evidence-based interventions. Social workers are uniquely trained to provide a strengths-based and person and environment perspective. Next slide, please. So then the question of why. There are many theories and frameworks about why and how role discrepancy surfaces. Some of the thoughts is that our role is so all-encompassing, or when someone doesn't know what to do, it becomes, let's ask the social worker, and then we just kind of figure it out. But at times, the task at hand doesn't require a social work degree, thus taking time away from other buckets of work. And this commentary about this dynamic in particular seems to be overwhelming within our discipline. It could be attributed to the general medical social work job description and what a social worker is asked to do within the health system. The HTC social worker itself is a very unique role. The misunderstanding of general scope of practice is also demonstrated in multiple studies, may stem from unawareness around the varied levels of education that we have, the training that we have to upkeep, the licensure at our state level. And while some medical social workers might be equipped to address logistical challenges, help with meeting basic needs, others are clinically licensed and able to provide therapeutic counseling and interventions. This could point to underutilization if others are unaware of this. A potential misunderstanding of role may be from patients and families as well. I think of, when I first meet a family for the first time, I'll ask, what's your experience been with a social worker so far, if at all, just to get a handle on what they're bringing to the table. And one time I had a 20-year-old say to me, are you here to take me away from my parents? And I just kind of laughed because I'm like, you're 20 and I will if you want me to. I don't know. It was just kind of became this joke, but it was very, that was their experience. The other thing I'll say, I will challenge you to find a social worker depicted on TV in like Law and Order and all that stuff that has 1 ounce of style or is remotely funny. Like it's just, the depictions aren't out there that are accurate. The other thing, it might also be an individual team member's personal preference or bias around certain psychosocial topics, which is exactly what a social worker is trained to work on, to lean in and to really hold space. So all that said, as a group, we set out to identify how much HTC social workers and HTC staff perceptions on our role actually line up. We wanted to see if that could be pointing to why social workers are feeling like they aren't spending their time in the way that they think is ideal. And with that, I'm done. I will pass this over to Kathaleen.
Thank you, Amy. So thank you, Sam, for switching slides. So she gave the background, and now let's talk about what we did with this. As Amy mentioned, this conversation happened, among the social work working group at Anaheim in BDC in 2018. So what we decided to do was, hey, why don't we apply for this NBDS Social Work Excellence Fellowship grant? It was definitely a little bit intimidating, a little bit nerve-wracking, but we joked that we're doing a lot of these things anyway. Why aren't we documenting it? So that was kind of our motivation to apply as a group for the grant, which we were awarded. And it funded this project. So we did a cross-sectional national online survey in 2020 to determine the views and attitudes of what the social work role is by the HTC staff. As Amy mentioned, there is historic research of HTC social workers that, demonstrated what our role is, what we see our role is, what we're doing versus what we think we should be doing. And maybe one of those gaps is, what does the HTC staff think we're doing? So as part of this, we wanted to provide a deeper understanding of the HTC staff perceptions about the social work role. Again, we know what we're doing, but as Amy blatantly stated, if we're not sure what each role is doing, are we providing that optimum care? And then we wanted to clarify if there were discrepancies between the social work and the HTC staff. And then we wanted to aim to improve the collaboration amongst the care team members in meeting the psychosocial needs of our HTC patients. We wanted to discuss what are the views and attitudes of what the social work role is by the HTC interdisciplinary team members nationwide. So when we sent out this study, this survey, it went to everyone in the CDC website, everyone that NBDF had. So we wanted to get everyone's opinion who had a touch point in the HTCs with social workers, what they thought we were doing. And we wanted to build on the 6 buckets that were originally highlighted from our from previous studies. So we also wanted to figure out what were these knowledge gaps among the interdisciplinary team members at the HTCs regarding our skill set and the capabilities, so we could empower ourselves and other social workers to advocate for improved role clarification and supports going forward in the practice environments, because all of this ultimately improves patient care, and that's what we're committed to. Sam, you want to go ahead and change for me? Okay, so these right here are the broad categories. We wanted to figure out what were the staff perceptions of the social work roles, and these are by the different categories. So as you can see, there's not really a significant difference in people's awareness. In some things there are, but most of the time people were right on track. Of the 6 broad categories, social workers and HTC staff both identified counseling, financial insurance, and outreach as the top 3 roles. However, the HTC staff endorsed counseling as the highest acuity, while the social workers actually identified financial and insurance as the highest. Now, the next slide, I'm just going to brace everyone for it, is very busy, but we're going to tease out a few things on this. So that for the slide that we were just at, there was some differences, but nothing overwhelming. Now this, when we looked at the subcategories underneath these broad buckets of counseling, grants research, case management, financial insurance, outreach, and administrative, this is where we really saw that there was some discrepancies that, if we're aware of the discrepancies, we can improve, right? So in counseling, both groups, as you can see, rated psychosocial assessments highest. Social workers did report that there was more time on adjustment to illness and grief counseling, 77% versus 67%. And then crisis intervention, 80.3 versus 77.4. While HTC staff reported more time on individual family counseling and support groups. And we thought this was interesting, and it brought up a very good conversation, was the understanding of definitions too. Us as clinical social workers, we are looking at counseling and support groups through a different lens than maybe some of our interdisciplinary staff. So that is a learning opportunity as well. Some of the quotes that came from this particular one is that the social worker's involvement in individual and family counseling is crucial, freeing up time for clinician to focus on clinical issues. So this is wonderful. Like, they see what we're doing and they're very, very appreciative, which we love. But what is that discrepancy, right? We think once we pulled all this information together and we come together, how can we educate them so we are allocating our people as they are needed? In grants and research, there was more time spent compared to HTC staff in managing grants and reporting. As you can see, there's 23% versus the 13.2%. That's pretty significant. That's almost half, right? So a lot of social workers are taking over the MCHB and CDC grant projects and managing those. And then also HTC staff reported more time that social workers were conducting research and writing articles, which was 19.8% versus the 16.4%. So again, I think it just comes down to something retrospectively, is there is a lack of understanding, and we are looking through it through our lens with our education and our background. And this is the peripheral, our teams looking at what we're doing. Case management, we are heavily involved in networking and resource sharing. So as you can see, that's 90.2%. And then linking patients with community programs was also rated very high, 90.2%. So a lot of time spent with that. And then HTC staff actually perceived more time spent on discharge planning at that 31% versus the 24.6%. I thought another interesting one was the documentation. As you can see, there's a big significant difference there. The HTC social workers rated 86.9% of their time doing documentation, while the staff, HTC staff, perceived 62%. So. And I really just want to pull out some of the quotes. We got a lot of rich feedback in quotes too. So one of the quotes was, social workers often handle extensive documentation, a task that might be overlooked, but is vital for patient continuity of care. So a lot of the documentation, working with communities, working with schools, working with other systems, a lot of time spent there. And then the social workers network and resource sharing skills are indispensable in connecting patients with the right support system. So it's right that a lot of time is spent there because it benefits our patients. In financial and insurance, the HTC staff, you can see they perceive social workers spending more time on assisting with insurance benefits, 84% versus the 73.8%, and advocating with insurance services. And then social workers reported more time on educating patients and families on insurance. And something that I want to point out here is there was definitely in our research paper some confusion that we are normally the conduit in helping connect people in applying for benefits, not actually completing the benefits for them. There seemed to be some understanding that we were filling out Social Security applications and filling out health insurance benefits, and it's more connecting and educating our patients about them. Okay. And a quote from there was just the importance of social workers playing that crucial role in educating patients and on their insurance options. And this is also was voted as a task that was underestimated by many of the other team members. Outreach programs. So social workers reported higher time spent on home visits, school visits, program development, and fundraising compared to HTC staff. And the greatest differences were in speaking engagements, where speaking engagements, you can see it is 59% HTC social workers versus 47.2% on HTC staff. And fundraising was 50.8% versus the 34%. HTC staff perceived more time on community education, 67 versus 62, and hemophilia camps, which was 62 versus 45.9. And I think something to consider too is that not every HTC is involved with the camp as much as some of them might like to be. And then also in the administrative category, social workers did report higher time in data and oversight. That's 21.3% versus the 16%. And then the public health service and 340B hemophilia factor program, 29.5 versus the 13.2, which I think is very significant. One of our presenters today is a program manager. And then the HTC staff reported more time on working groups and committees, which was 53.8 versus 47.5. So as we're looking at all of these discrepancies, we want to recognize that both social workers and HTC staff largely agree on the importance of counseling, financial insurance, and outreach, but these notable differences in the time allocation as well as the emphasis. Difference in perceptions suggests that while the roles are broadly understood, the specifics of each subcategory reveal some significant variation that we hope to address. This just continues to highlight the need for clear role definition and better communication to align expectations and responsibilities. Additionally, I just want to point out the flexibility. As you can see through these large, broad topics and then all the subcategories, social workers are very flexible. And that flexibility is both an asset and a challenge. It enables the social worker to address a broad range of needs, but again, it can actually also add to the role confusion that we are seeing here. And it also overlaps with other team members, creating occasional conflicts. This flexibility often results in the underutilization of the social worker's full scope of practice and licensing potential. And sometimes that can lead to frustration from both the social workers and the HTC staff, as well as disrupting these timely referrals for optimal patient care. All right, a quote that I just want to share from there again is the value and impact that social workers are highly valued for their comprehensive role, which allows medical staff to focus on the clinical care. And then comments praised social workers for their resource knowledge, mental health assessments, and ability to navigate financial and insurance challenges. So this supports the view that the clear role definitions and understanding can enhance collaborative efforts and patient outcomes. So very busy slide. I appreciate you guys navigating that with me. So let's move to the next slide, because another part of our research was talking about the barriers to using social work. A big one was the time and financial constraints. So the one thing that did come up a lot is that some HTCs struggle with social workers being part-time or sharing their time across departments, which can limit their availability and the effectiveness. Sometimes they have several roles outside the HTC that also take up their time. And then also high caseloads. Social workers and HTC staff identify high caseloads as barriers to fully utilizing social work skills, which can impact the ability to address our patient needs. Okay. And structural limitations, this was something that was brought up, is the limited hours of operation, sometimes high turnover. People always joke that social workers at HTC are either there forever or they exit pretty quickly. And that data is noted within our survey as well. So low salaries can add to that additional strain, impacting the social worker's ability to perform. Administrative burdens, data entry and reporting requirements for different projects like ATHN and CDC registry add to the social worker's workload, which can detract their time spent on direct patient care. One of the things that Amy mentioned earlier too is sometimes that there can be like some conflicts in maybe a misperception in the willingness to engage in certain tasks or conflicts with social work preferences. So that can also be a barrier to fully utilizing social work. And then communication barriers. If there's inadequate communication about the psychosocial issues and referral needs, there can result in missed opportunities for social work intervention. Some of the things that were brought up is that, your social workers, they do have, most of them have masters in social work degrees, and they do have very specific training. So sometimes when there's a need and it doesn't come across your social worker because there was a lack of understanding, it was just that missed opportunity to immediately intervene and support our patients. Some of the quotes from social workers is just time limitation due to high volume of patients. During clinics, I feel like I don't always have enough time to fully assess current needs. And sometimes people, they don't have someone to do the data collection or input, and the social worker ends up stepping in sometimes and for the Athens data set or other opportunities. And this person said, that they're being paid the same as the hospital social worker, but their roles were just very vastly different. And I think that's something too, when you think of a barrier and the social worker maybe not being designated specifically to the HT and sharing across. So that role confusion and frustration, just things to be aware of and things that we can potentially advocate for. There's also, in our research, it surfaced some perceived lack of respect for social workers' clinical skills and contributions, leading to missed referrals and underutilization of their expertise, which I just mentioned. Sometimes people just aren't aware of what the background, education, and training is to be a master's level social worker. So how can we make sure our team is aware so we're utilized effectively? Community resource limitations. So sometimes the limited availability of community resources and geographical barriers impact the social work's ability to connect patients with necessary support systems. Someone in the survey shared that they served a state where the majority of the state was not on a road system. And, I think some of us, when we're looking at this vast collection of HTCs, we forget about those, but it's very real to a lot of our social workers who can't even get the basic resources to access. Distance, transportation, limited referral options, especially in some of our more rural areas. And then professional time constraints. Insufficient local services and professional time constraints can limit the social worker's ability to provide that comprehensive care. So barriers to utilizing social work services effectively often stem from time, staffing, structural limitations, interpersonal issues, communication gaps, and those limited community resources. So if we start to address these challenges, it could be crucial for maximizing the impact of the social worker role in the HTC. Go ahead, Sam, move forward, please. Okay, so how can we? We said these are the discrepancies and these are the barriers. So let's problem solve. What can we do moving forward? We want to enhance and strengthen that psychosocial services and supports within the HTC. We want to educate key stakeholders about the HTC social worker, educate the medical and interdisciplinary teams on the full scope of the social work roles and how to best utilize their skills, and provide clarification on what social workers can and cannot do to optimize their integration into patient care. For patients and community, we could increase awareness about the comprehensive services that social workers offer. One of the quotes from that was impactful for this was, our social workers are visible and they have a strong and robust role, but if anything, our medical team may need some clarification on how to best utilize. So there is that insight that people do want to learn more. Promote. The need for promotion and advocacy. Use organized national platforms to highlight the social work role and its impact within the HTCs. Thank you, NBDF. Address outdated or negative perceptions of social workers. Amy just mentioned that earlier, the perception of social workers that I think we all get. Sometimes you walk into a room and they're like, I don't need a social work. And it's almost this defensive, and even on, television and movies doesn't have the best role. So what can we do to improve that perception and take back the positive things that we do? So promote our value through various media. Engage in broader advocacy and research to support the social work profession. And then also foster educational gatherings and virtual platforms to enhance an understanding of social work contributions. So I think today is a wonderful step in that direction, and we are appreciative of it. One of the quotes here that I thought was impactful under promotion was having an organized and national platform will be valuable. It would be important for the institutions which house the HTCs to be fully aware of what is being offered. Also, strengthen internal advocacy. Social workers should actively advocate for their role within their own centers, highlighting their skills in mental health assessments alongside the financial and insurance support. Outreach, finally. Introduce social workers to patients and families through proactive outreach and regular check-ins. Introduce social workers in community events such as summer camps. You want to build familiarity and approachability. Looking at different community-based events. You could increase social work involvement in some of the mentoring programs, bring them to camp, and then also utilize NBDF guidelines and support with their program development that would increase social workers' ability to conduct community needs assessments and improve new programs that address the community needs and expand that social work impact. So basically, to enhance the psychosocial presence in HTCs, we need a multifaceted approach. We need to secure additional funding, educate and advocate for our roles, strengthen both internally and externally, and proactively engage with the patients in the community whenever possible. So these strategies could fully leverage the social work role, improving patient care and support within the HTCs. So that's my portion of it. I'm going to pass it off to Diane, but I hope I really highlighted and did social workers justice based on our research to be as braggadocious as possible. That was a term that surfaced during our research, and I need a t-shirt that says that. So
thanks, Kathleen. Yeah, so next slide, please. I wanted to just kind of circle back to some of the key talking points that have already been mentioned. Our study successfully, the results concurred with previous conclusions regarding the knowledge gaps of social work scope of practice, both within the bleeding disorder arena and also in other disease states. And so that was encouraging and discouraging, I guess. They highlighted both our study and others, the challenges faced by many of the social workers in regards to the current interdisciplinary team placement. And I wanted to just address one thing that I constantly have in the back of my mind that has been said throughout my career by mentors. And that is that our goal as social workers is to work to the top of our licensure and utilize the highest skill set possible. And one of the things we did not share today were some of the demographics of the respondents, but Amy briefly touched it, where I think it was like 87% of us are master prepared social workers. And of that, a large, over 50% of us have clinical licensure. So what that means if you're not a social worker is if we were not in a medical setting, we could hang our shingle out front and do private therapy. We would oftentimes be upper management tiers in a healthcare system. And so when we're looking at some of the skills, the roles of social workers have really evolved since the early 1900s, and even in the 30 years that I've been a social worker. And so it's not that I can't do something, but does it make sense as a clinical social worker that I'm doing it? Or is this something that would be more properly suited for a bachelor prepared social worker, or perhaps an associate degree individual? And Of course, I have a little bit of bias, but a key example of that is in the financial and insurance side. That is a huge need of our patient population, but I don't know as a clinical social worker if I'm the best suited for that versus in our healthcare system, we have patient financial advocates that assume those roles. And so that's just one example. I also want to speak a little bit more historically of the roles that social workers have played and in the different arenas. And so in our talk today, we're really focusing on medical social work. But historically, social workers have been resource specialists and patient advocates within the greater healthcare setting, a lot of assistance-oriented tasks. But over time, as I just mentioned, that's really evolved to have more clinical practice in our work. And now we have formalized licensing across the United States. And so it looks very different as a medical social worker today than it did back in the early 90s when I first became a licensed social worker. We need to tease out and figure out how we're going to highlight the potential impact of implementing these discrepancies, and again, utilize the social workers to the full scope of practice, their licensing potential. And this is really vital because it's one of the things that frustrates social workers the most. And so we have to have this need, as previously mentioned, to educate not only each other, because some social workers are the only social worker in their HTC or that they work alongside. So we need to educate within our network, but then also more broad. We need to continue to seek greater understanding. And it's important because we want to have workplace satisfaction. We want to have strong retention. We want to have resiliency within our team, and we want to provide the best care possible to our patients and families. So I think it would be a disservice if we didn't address some of the results from the study. Next slide, please. So I wanted to spend a little bit more time talking about these 4 buckets. And again, I look at this from a unique lens. As previously mentioned, I was an HTC social worker, and then several years ago, I was promoted into the program manager role. And I'm very great. I have so much gratitude for the trailblazers in the bleeding disorder arena that have taken and assumed those roles prior to me. And it was through the social work working group that I first met some of these individuals, and they helped mentor and helped me advocate for that role. It did not come easy, so it really, I have that lived experience of what our research design addressed, of having to go in a large healthcare system and advocate for why it might be best suited for myself as a social worker to have wear this hat and have this role versus perhaps a nurse or a public health individual. Why would I best be suited? And I had to do a lot of advocacy and education about what entails getting your master's in social work, and how I have a research background because we have to do a graduate thesis project at that time. And in my program, it was not a generalist program. So there was an administration planning track, there was a direct practice track. I was a finance major before I ever became a social worker. So just because we have our master's in social work, we have our bachelor's and other degrees. And so that's not uncommon to have a skill set like business administration or psychology, and some have bachelor's in social work. So it's a very unique situation where oftentimes other medical professionals have most of their educational background in one area. Financial considerations, boy, have I had some real lived experience on that. And the healthcare model is always evolving. And there's some ambiguity, there's some need for advocacy that were highlighted in this study in regards to that. In a comprehensive care study, in a comprehensive clinic setting, which we actively utilized, traditional counseling takes place in a really fragmented way. So this is different than other medical social work positions where they, for instance, I was an oncology social worker prior, and the expectation was close to 50% of my time spent would be seeing individuals one-on-one in therapy, and then the other would be that resource allocation. And in a comprehensive care model, that was one of the challenges. If we're seeing someone once or twice, 3 times a year, and it's all these other disciplines trying to see them as well, it's very fragmented to be able to do therapy in that setting. And so that also has an impact on our billing structure and our coding. So it's not uncommon for social workers in the HTC setting, perhaps to have an MPI number. We could bill if we wanted to, but it doesn't make sense to because it's hard to capture those codes and that revenue. Then when you're looking at it from a larger healthcare perspective and you're talking to someone from the finance department, they want to know, why are you not billing for your services? And why are other disciplines not billing for their services? Organization-wise, some of the barriers, of course, being part of a larger system or a healthcare structure, there could be policies, there could be financial and staff resources that are barriers, communications. These are some of the themes that were echoed throughout this research design and the previous ones. What we resoundingly know is that the HTC staff value the role of a social worker, and oftentimes collectively they acknowledge the FTC, the full-time equivalent or the hour status of the social worker, and the type of caseload can also impact the patient care. So Amy and Kathaleen both mentioned that some social workers share their duties. They might split their time, and it's just a tiny piece of the pie of bleeding disorders. And so that time is really not protected, although it's supposed to be protected. And that can go across disciplines. And so then the ideal situation that I would advocate for is to have designated protected time of the social worker, understanding all the different roles that they play. And so they're not pushed and pulled between other large programs in their setting. I think it would be interesting for future research to really take a look at these resource allocators and the key stakeholders or the administrative decision makers, and what the benefit would be, the cost benefit, the patient care outcome benefit of having a robust social work presence on the interdisciplinary team. And I would argue that if you have good, strong FTE status and you have that as a protected allocated time, that would have a direct correlation, a positive correlation on improved patient care, patient adherence, satisfaction, both of the social worker and the patient families. It would impact experience and, truthfully, the overall bottom line. It would be advantageous for sure. Now, the uniqueness skill set of the social worker, I've kind of mentioned a little bit for those of you who aren't social workers, but it really just reaffirmed how unique the field of social work is. It's very broad, and we oftentimes like to say it encompasses a micro, a meso, and a macro perspective. So what I mean is micro, think of the small units. That's direct patient care. That would be my clinical skills in collaboration with the patients and families. It could be my professional presence on an interdisciplinary team. It could be case management. Meso is kind of the median ground. And when I think of that, I think of my little bit broader love circle in my sphere of influence. So I'm thinking of the Idaho chapter. I'm thinking of outreach to the more rural areas. I'm thinking of program development and how growing and enhancing our program within our HTC. How can we have that as a touch point to the greater healthcare system? And I'm thinking of quality improvement. Quality improvement more on a meso scale would kind of be actively sharing the outcomes of the QI projects that I have at the HTC with the St. Luke's Health System. Showcasing, in sharing our publication, that we did a podcast, that we're speaking today. And it goes back to Kathaleen's thing. Sometimes people feel a little insecure, it feels a little uncomfortable. Someone might ridicule and say, oh, well, aren't you braggadocious? No, you know what that is that's advocacy. That is self-promotion, but not in a conceited manner, but just more in an awareness manner. It is showcasing the great work that we're doing in the HTC and how other people across the healthcare system could replicate something, or not reinvent a wheel, but could use that as a launch pad, or give themselves permission that, hey, you know what? If Diane can do this with her colleagues, why can't I do this with my colleagues in a different disease state? Kind of demystifying that. Meso is also collecting data. So I think of, it's micro if it's just at St. Luke's. It's more of a meso if it's within the Mountain States region. And it's a little bit more of a macro perspective when we're looking at it collectively across the nation. And last, on the macro roles, we cannot minimize the advocacy or the education that we do, the legislative stuff that we do, the being a conduit to that, being willing to go outside our comfort zone and maybe attend Washington days. There's so much more. Every opportunity that you can do to showcase that what your role is and how you're making impact, not only in the bleeding disorder community, but perhaps to others in other healthcare settings. Traditionally, social workers have not been considered for administrative positions within the HTC. Again, I mentioned this. I feel like the direct knowledge, the direct practice care experience, and the knowledge of diseases, patient issues, staff concerns, and the mediation and interpersonal skill sets of social workers make them the obvious and ideal fit for these leadership opportunities. Interestingly enough, there's a field of study called integrated healthcare teams, and Dr. Lombardi had directly stated in their research designs that a social worker would be the ideal fit for the healthcare manager role for that. So if you're not familiar with the integrated healthcare model, I just wanted to share with you the World Health Organization's definition. And they define that integrated healthcare as the management and delivery of health services so that clients receive a continuum of preventative and curative services according to their needs over time and across different levels of the healthcare system. So when I first read that, I was like, well, duh, that's what we're doing in our comprehensive care model. So integrative healthcare teams focus on a specific disease or age group with the goal of multiple services at one time. So kind of being a one-stop clinic. And we very successfully do that within the bleeding disorder community. So last, I wanted to talk about the clinical practice and research. And this crucial function, again, I feel is ideally suited for social workers. And because we are trained, for those of us that had to defend our thesis and do a research design, we understand the importance of evidence-based care in our practice settings. Going back to the data of the research design, though, about a quarter of the social worker's time is spent with our CDC and NCHB roles. And I think that could be a big aha for a lot of people on this call. Like, really, 25% of your time is spent doing that aspect. But oftentimes our colleagues don't see that as like research necessarily. They think we're publishing papers. Some of us are, but that is collectively in a research bucket. It goes to a greater research bucket. So Kathaleen and Amy also mentioned that more and more social workers are also responsible for Athens data set and doing those reports for our regional coordinators and then presenting them on the national level. And that, I would also say, is in that clinical practice research bucket. And then last, the grant the grant responsibilities of having QI projects within your HTC and participating in a regional level. Most social workers, I participate in that when I go on the Mountain States calls. Many social workers at the different settings are participating in those. Next slide, please. So, oops, sorry, slide just hit my nose. So in conclusion, I just want us to go back and express gratitude for the groundbreaking studies that had previously been done. I'm so grateful for us having an opportunity to go to national conventions and network and sit and having conversations over cocktails and margaritas and deciding, hey, maybe we should do a research design, and then going for it and doing it in a small group. I loved that we had that opportunity. I also wanted to I think we collectively agree that there's some role confusion, and it's in the need for some clarification. The best outcomes, patient care outcomes, come from a common focus within our interdisciplinary team and strong communication and reliance on one another. Social workers are trained to address person in the environment and understanding group dynamics. We can offer a strengths-based lens, which is how we operate in our discipline, versus that psychopathology lens, to both audiences, whether those are internal or external. Internal being our colleagues, and external being our patients and families and other key stakeholders. We want to be sure that social workers are functioning at varying levels of the capacity within their HTCs, and that they're recognized for that. So advocacy, both by social workers and by their leaders and medical directors, is so important. We need allies, and those come from the interdisciplinary team to help us define the roles, help others understand the variance of the roles, to elevate the social work's role to equal the education and the skill set that they bring to the table. And then our hope is that there would be resource allocation and growth moving forward. Next slide, please. So really quick, where do we go from here? Well, Kathaleen and I recently, June 28th, we did a podcast on bloodstream. We are in the process, the three of us, with some other individuals that are interested from the social work working group. We're getting together, and we are actively working on creating guidelines that we will then, for psychosocial care, that we'll present to the social work working group, and then hopefully for MASAC for approval. And as mentioned, we're going to continue talking. We're going to continue to share our research, share our thoughts with anyone who will listen to us. And we're going to actively seek allies in this process to help us with this promotion of our role on the interdisciplinary team. Next slide. I think it should open up for questions if there are any.
Wonderful. Thank you so much for such a comprehensive overview of this amazing research. I'm going to stop sharing my screen. We have about 5 minutes left, so I do know there have been a couple questions that have come through, but first we want to start with a wonderful sentiment from one of the attendees. It was not a question, but just wanted to honor the role of the social worker. They have my utmost respect and appreciation, and I think that could be said for everyone that has tuned in today. So thank you so much for this comprehensive research overview, and it's obviously just the beginning. So with that, we want to ask, thinking of the Excellence Awards through NBDF and how a Social Work Excellence Award has been awarded every year thus far, based on the research that you have done, what recommendations do you have for social workers who will apply in the future for other projects that could either build upon or other parts of the role evaluation that were not addressed that you were like, oh shoot, I wish we had looked at that?
I'll take that one. I think one thing that we had discussed as a group as we started going down the path of trying to figure out what could be leading to the discrepancy or underutilization. Within this study, we weren't able to capture what do patients and families think that we do. Is there a discrepancy there? And is there room for us to tailor our education, our promotion of ourselves to them so that they feel more empowered to access us? They might not realize my HTC social worker could help me with that, and that's another avenue. I guess advice I would have is use your community. If you're interested in research, even in the slightest, Samantha has always been a wonderful resource for us. Maria, everybody at NBDF, as far as going down the path of seeking these excellence fellowships, brainstorming research, working with others. That's my advice, I guess. It's not as scary as it seems.
Excellent, excellent. Kathaleen, Diane, any other additions?
I was just going to add to that. I mean, it was very intimidating, but much like the rest of the Hemophilia Treatment Center and NBDF community, just the wealth of support. It really just was encouraging getting to work on a team with people. So, we said this throughout our project. We're doing so much of this. Why aren't we, we're documenting it other ways. Why don't we document it, quantify it, and put it out there to share with everyone else?
Excellent.
And one thing I would say is, it was daunting. It had been a couple decades since I had published. But one of the things that retrospectively I realized is taking the leap of faith and doing it with some other awesome colleagues actually helped launch more visibility of the Hemophilia Treatment Center in my institution, because I had something tangible that I wanted to share. And so it was easier to share that. And they were happy to do so. And so that's been really exciting to get that information out of just the HTC and into a broader community. And so it really enhanced my professional development, I think, which is what, for retention, is what I really was seeking. I wanted to do something a little bit different. We had mentioned that most HTC social workers, there's this gap. They're either really new or they're seasoned. And so sometimes we need these opportunities for professional growth later in our careers to keep us engaged. And so that comes with the community presentations. It comes with engaging with outreach with our chapters. It comes with, these types of research designs. So just do it.
Good plug. We'll certainly make sure that folks have the connection to this recording, as well as how to apply should some social workers want to apply in the future. We've had a couple questions come through. I don't think that we'll have time to go through them in the 2 minutes, because we could clearly go for another hour having a conversation about this wealth of knowledge. So we will email those to you so we can do some follow-up. But one that should be fairly easy, and Amy and I have talked about this in the past, would there ever be extra certification for the MSWs and HTCs that they could obtain to be specialists in HTCs to amplify their role as well as potentially their pay?
Well, I can speak. Well, yeah, we have certification pay in our healthcare system. I do think that would be great if we had something like that within the bleeding disorder. But in this meantime, I think if there was any extra certification, I think we could easily piggyback the NASW healthcare certification. And then that kind of encompasses those individual specialized disease states. And so, it's not directly always to bleeding disorder, but I would encourage that.
Wonderful. As a reminder, there is an Ask the Social Worker at bleeding.org email address that you can send in, and the social work working group addresses those questions as well. So we can drop that in the chat, and we will follow up with attendees with some of the resources discussed and the paper and the amazing work that you did. Thank you so much for your wonderful overview. We hope to see you all at BDC in a couple weeks, and thank you for joining us today.